First of all, I want, if this thing goes on, signal me. My back is to it, so I can't see. We have bells and whistles, but no pictures. I want to give a little bit of time talking about the paper. Quite a few of you have sent in the name of your topic that you'd like and even the outline. That was supposed to have been sent via email to me. You realize that? And on the syllabi, I think it says next week is the last week. So don't look at one another for answers. Just read what you're assigned, and you'll do okay. I'm changing that direction now, and those who are not here do not hear, and that's their problem, all right? Since there seems to be a very slow response sending in the topics and the outlines, you're not responsible to do it anymore. What you're responsible for is to do the paper. So if you send it in, you get extra help. Obviously, I've responded. I've told some of you that this is an undoable topic. It's too much for the 5 papers that you've been assigned. You can't find enough. What were some of the other comments? This is a very debatable issue. Someone that talked to me today before class, asked me about whether or not healthcare providers with HIV can minister to people. We spent a fair amount of time last week and the week before talking about this right in class. So it tells me you're not listening, but that's okay. If you don't listen, you're responsible for the final grade. If you get a fail, you get a fail too. But for policies with HIV, I told you to go to nursingworld.org. And in the left-hand margin, there is a place to click for policies. Those are professional policies, and it will tell you what the American Nurses Association says about that. And I told you that ANA says that the responsibility is the individual nurse. If you are infected, you're responsible to avoid types of work that would infect a patient. Which means, you remember I used the words deep, dark, and sharp. Anything where you're working in a body cavity, where you're deep in it and you can't see your hands all of the time, and where you're using anything that could puncture your skin and allow you to bleed onto another person. That means scissors, sharps, they're called, of any kind. I don't think you're going to understand if I use the word a scalpel, but it's any sharps, needles. You don't ever use those things and have them out of your sight, because if you have HIV and you prick a finger and blood gets onto that other person, you're exposing them. If that should happen, you are responsible to report it and to tell the person. You have to tell the patient. I'm infected. Some of my blood might have gone onto you. We have a normal procedure here, and every hospital and home care agency, nursing home, any organized setting for care is responsible to have a procedure. which means testing, the administration of gamma globulin, which is a natural defense for infection. And if you're writing about this, the American Nurses Association policies are not enough. You have to go into the AMA. And I would surf around to other professional provider organizations and see what they say. But critically, there is a difference of opinion. So if you're looking at that topic, you have to provide both pro and con. And then you can come up with an opinion of your own, or you can say, it's very confusing. I've read a lot of different opinions. I have no one that I would accept as my own. That's okay too. That's how you would go about a topic that has 2 points of view. How do you know if it has 2 points of view on anything you're writing about, like physician-assisted suicide? One of you is looking at that, and you sent me an email. I sent it back, and it was very well done, because you one of your points in your outline was positions that are pro, positions that are con, and then your own opinion. If you look at the rubric or the detail on how it's graded, it jumps out at you. You have to have 2 sides of something that is controversial. And you only know if it's controversial if you go, you surf around on the internet, and if discussion comes up on both sides, then you know it's controversial. But that's up to you to find out, not me to tell you. All right? What are some of the topics that you're thinking about? Please get used to speaking in public. One of the seniors, I don't know if I mentioned this last week. Last week is a blur after the snow, and we're getting more, this Saturday and Sunday. And there's a big storm anticipated for next week. So just to make you happy to hear that. But regardless of whether you hear or not, make sure you hear everything that's said. So, what are some of your ideas about topics? Oh, I would hold it 1 minute. A student came to me, a senior, and she said she's getting the idea, she's in the last course in nursing, the leadership course, and she's getting the definite idea that in order to make it in nursing, you have to be assertive and able to speak to groups. You do. If you're reticent, you ain't gonna survive in this, because you have to speak up to other healthcare professionals, especially you are responsible. So when a doctor orders a medication, let's make it scary for you, that you think is too much, and you know the practice area that you're working in, it's up to you to say, sir or madam, you ordered such and such a dose. Are you sure that's what you want? And they say very self-righteously to you, yes, you just give it. I'm uncomfortable giving that. Do you want to look it up? No, I give the orders here. All right, you give the orders, you can also give the dose. You have to be assertive and comfortable on your feet. And this disturbed her because she felt in clinical post-conference she was not getting the best grades, and she wasn't. And it wasn't that she didn't know the stuff. She didn't speak up. So you have to get in the habit of speaking up, speaking out, contesting opinions other people have. So with that, what's your topic?
Polypharmacy. You talked about it last week.
Yeah, very good. Polypharmacy. you will find that that will direct you almost exclusively to the aged client. And polypharmacy, if I were looking it up, I hate this thing, but it serves its purpose. All right, I'm pretty loud. Everything is non-functioning here. You will find that, in general, polypharmacy is a problem in the United States in general. If you go into the Robert Wood Johnson Foundation, they do a study every year that's called Days of Medical Practice. And it tells you, it informs you about what the common practices are in medicine. And I think at its last sharing of data, 95% of people who go to a physician walk out with script. Script is the word we use for prescription. Everybody thinks if you go to a doctor and he or she doesn't give you a prescription, they don't know what they're doing. It's like they're witch doctors that have a kettle of something, got to reach in and get the perfect drug for you and you're going to be cured. If you go to some providers who suggest for a cold, you go home and stick your head under a towel and let a kettle boil in front of you and inhale the steam, and go to bed and take a hot cup of tea, which is the preferable, and sweat it out. They think, what did I pay my money for? They want antibiotics. And antibiotics are currently proving very negative for the population. We've used so many of them that there is not another generation, well, two things. Personally, there is not another generation of antibiotics for you to take if you get really sick. And number two, with every bacteria that you combat through using antibiotics, bacteria are very smart. They generate a new strain of bacteria so that the drug companies have to go and try to concoct new antibiotics, and we're going to run out of potions at some point. So that topic is very good. You could look at polypharmacy in the elderly. You could look at polypharmacy generally, although that's a much broader topic. You could look at the use of antibiotics exclusively in the U.S. population. Okay?
I was just surprised one day when I went to the pharmacy with the script, and and some of the person in the pharmacy, they don't know the name of the actually the diagnosis that the doctor just prescribed, on the script. It really,
They don't know the diagnosis. They don't have to know the diagnosis.
Yeah, but,
they didn't know the drug that was prescribed. Are you saying that?
Yeah, but like for example, the verticulitis. This is something like they should know what is this. I couldn't even read what was on the prescription on the back.
Well, the doctor doesn't, or the provider. We shouldn't say doctors because it's not just doctors anymore. But the provider doesn't put down the diagnosis.
No, he put on a separate, and I couldn't read what
the drug was.
Yeah.
That's common.
Yeah.
And usually, what the pharmacist will do.
I didn't know. He searched on the internet. Just let me know what is this.
To look what the drug was.
Yes.
All right. Number one, more and more doctors are transferring their orders to pharmacies by email. And on email, you'll get a legible product. You'll be able to read it. Handwritten prescriptions are notoriously bad because nobody can read them. Now, to make it worse, there are two names for most drugs. There's a proprietary name and there's a generic name. The proprietary name is the name of the drug that's from the drug company. It may be the same drug in several drug companies, but each drug company uses a slightly different name. Providers are supposed to order the drug by their generic name, which is the official name. And I can't even understand ones out of my area. My area is psychiatry. I know those. But you start in to talk about the other drugs, it's very technical names. A pharmacist should understand them, but it does get very complicated. If a pharmacist can't understand, and if it's script that is handwritten, again, script, the name for a prescription, that's handwritten, usually what they do is call the doctor's office, call the provider's office, or get the provider on the phone and have them read it off and spell it off to them. In the U.S. right now, if you have a prescription plan, you are required to use the generic and not the proprietary, if it comes in generic. Like all antibiotics come in generics. To use the proprietary, a proprietary name might be 5 times the cost of a generic. All right? So you're required to use the generic. Unless the doctor specifies on, or the provider specifies on the prescription, use proprietary. Because some proprietary drugs have binders in them. That's a chemical to hold together the drug, and then it's put in capsules or it's put in pills. And the binder, with some patients that are very sensitive, will make a difference whether the drug's going to be effective. I would not take any topic like that because it's very complex. All right, other topics. Please, this is your opportunity. I'm not requiring you send it, but my prediction is that those who don't test out their topic are not going to do well. Additionally, there are examples on your list where your slides are of different term papers. You're going to find they're going to give you 100% plagiarism in Turnitin. They've been through Turnitin. And you must put yours through Turnitin and come up with a score around 30%.
Should school nurses be able to administer contraceptives and information over?
Should school nurses be able to administer contraceptives and what? Information on birth control. The third part to that, or refer to providers who can. In schools that don't allow that, they're not even allowed to refer. All right? Because if if you're in a school that's religiously based and this isn't allowed, what they used to do is refer you to someone else. But you can't even do that anymore. It's a very good topic, and you should find a lot about it in the current literature. But again, pro and con. Public schools, nurses are allowed. Religious schools, they are not allowed. You're going to get into that debate. So there are two sides. Good.
It's similar. Should birth control be an over-the-counter drug?
Should birth control be available without a prescription? That's what you're saying.
Yeah.
And particularly the day after pill. Now that is over the counter right now. Are all birth control pills prescription? I think so. Yeah. Why the difference? That would be very good. Make sure you get into all aspects of it. Okay. Anyone else? And remember, I think next year I'm going to take off the sample term papers because if I get too many on deck, I'm going to scream. You seem to be obsessed with that. Most classes, yeah.
How about patient medical home?
Yes. Now, that isn't an opinion paper. That's an informative paper, and that's okay. I told you there will be some things that you want to write about that have no argument about it. The medical home is one type. The medical home and the ACOs, the Accountable Care Organizations, are two types of coordination devices, let's call them that way, that are specifically named in the ACA, the Affordable Care Act of 2010. It's not whether you have an opinion, it's law. Until the Supreme Court or somebody else, well, it's law, but you're not mandated to have it. You're not. Now, you'd have to get into this. If I were you, I'd start with the Affordable Care Act and see what it mandates. It allows for these two. And both of them are used in New Jersey selectively. In other words, and I don't think that the general population understands, but would you go out and look for a plan? If you're poor, or if you're not poor, it's not linked. The poor and the underserved will have a right to choose from among a cluster of plans. I think it's 3. But everybody will have the option of going to government for the plans they suggest. Would you know enough, and I'm not asking you, but will people know enough to ask which one of these plans has a medical home? The medical home, and they can be headed by a physician, an advanced practice nurse. I don't know if anyone else, but you'll tell us in your paper, can be the touch point for these places. But a medical home is one place where you go for all your care. There has been a program used for years, which is similar, and you may find it helpful to go look at that plan, the PACE plan. PACE, it's been a program available to elders for years. And what it is one place you go for coordination of all your health care, for education around your problems, one person you see who will explain to you the nature of your health problems, who will set up your appointments. It's total coordination. A medical home. Yeah. But your paper, you may have an opinion at the end. Perhaps it would be that you think everyone should be aware of this and inquire if their plan provides this opportunity before you subscribe. Or you could just tell us about a medical home. It's an excellent topic. Yeah. Anyone else?
Can we just talk about the autism?
You spoke about that last week. Autism. I think you were interested in the etiology. What causes it, right? And you're going to find an awful lot. I mentioned to you last week an optometrist I know that has the contract for the state of California. I don't think the state of California would be giving out a contract to an optometrist or optometrist for treatment of autism unless there was some proof that stimuli and diversion of stimuli did some good. It's excellent. And that also would be a didactic paper, which means an informational paper. I don't know how you could have an opinion. You could have an opinion, but not one that's scientifically based in doing one paper.
I have a question. It's also good if you, I would just attach like some information about the behavioral intervention plan, like with children.
Oh, sure. Cognitive behavioral intervention is the big intervention for children with autism. It developed in Teachers College, Columbia University, the Horace Mann School, years ago, and most of the schools in New Jersey, and New Jersey, again, a plug for New Jersey. New Jersey is well known for its services for the autistic. Most of them are cognitive therapy. All right, what's cognitive therapy? Cognitive therapy is usually one-on-one, working very closely with a child, and reinforcing the skills as he develops them. Like, no, Richie, don't look over there. They're easily diverted by the stimuli in the environment. Look here. Here, Richie, and turn his face, and it has a heavy dose, too, of negative reinforcement. Very good. Other topics. All right, I hope you have been thinking more than this shows, all right, because the papers due early in the second half of the semester, and there's no extensions. Unless it is for something you're doing in the paper that's extraordinary. I gave you an example of some of my students who have done extraordinary things. So please, every time I say this is a good topic, write it down if you haven't got something. You're under no obligation, we did away with that, to send it to me, but I am there, so you're welcome to send it to me. But if you want to muddle along on your own, muddle along. You can do that too. All right? And that's it for the paper. We were talking last week, and I really was going to put it aside. You have enough guidance in your book. We were talking about nursing as a profession. We mentioned the Flexner report, which is very important. Flexner set the stage for understanding of what professions are. And he had a three-legged stool. The three-legged stool of healthcare is access, cost, and quality. Those are the three factors in healthcare. And in ACA 2010, in the Obama proposal, that supposedly we're going to impact, all right? Access, universal. Cost is going to go down, ho, 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 all right? And quality, all the things that have been done, we've referred to a few of them. We'll talk about them more as the course goes on. Like, if a patient develops an infection when they're in the hospital, if they develop pneumonia, if they're on Medicare, where the federal government pays, the federal government is refusing to pay for their care. Listen to that. That's critical. Your grandmother, your mother, goes into St. Michael's Hospital for, I don't know, something, but has no infections, no nothing. They're there 2 or 3 days, which is not odd. I don't mean poor St. Michael's. I don't mean St. Michael's, but any hospital. All of a sudden they come down with an infection, and before you know it, they're in intensive care for pneumonia. The government will not pay for care anymore. They're saying, if you have a place that promulgates these infections, you pay for it. And they've been doing that since last October. All right? The same thing if you screw up in the surgery that's done. The government will not pay for it anymore. And why should they? You're responsible to provide good care. You don't provide it, you eat the cost. That has been, and that's a quality issue. If you're an older person and you're discharged, and the hospital seeks to readmit you in 5 or 10 days, this is a game. They've done this for years. The government is refusing to pay for the next admission if it's within 30 days. They should have kept you and cured you. So this is why hospitals have fewer patients and hospitals are going under financially. So quality, cost, and access are the three-legged stool. Now, the three-legged stool of the professionals is education, autonomy, and uniqueness. And in one of your first slides, if we had them, but you had them last week, and I'm sure all of you have them in your hands now, there's characteristics of professions. If you read them, they all come down to those three: education, autonomy, uniqueness. Uniqueness. You do something very special that people need. Therefore, you're considered a profession. And a profession is a very special field of work. People give professionals a lot of latitude. All right? A lot of respect. So, in 1905 or so, the first Nursing Practice Act went through a legislature, the North Carolina legislature. And the people in North Carolina recognized that nurses do something unique, and they should be recognized in the law. And from that date on, New York was number 2, Jersey was number 3, and the states, little by little, began to recognize nursing as a freestanding occupational area. I have questions whether it was a profession at that point, but a freestanding occupational area. Education. There is special education for nurses. It takes place, for the most part, in institutions of higher education, be it a community college or a senior college. And we can't X out community colleges. They're preparing a lot of nurses, even though we don't think it belongs there. It's the opinion of the profession that the minimum preparation should be the bachelor's degree. All right? And the marketplace is taking care of it. For years, we promulgated policies through the American Nurses Association. We tried to convert into a totally baccalaureate profession. Nothing worked through legislation. Now we have the magnets Who doesn't know what a magnet hospital is? Please feel free to raise your hand. You all know now. Most of you. Do you? All right, we've mentioned it here. Those are hospitals which are accredited by the American Nurses Credentialing Center. Their nursing services are accredited, and they stand above the rest. Now, why are they called magnets? Sort of a silly word. It came out of a research study in the 60s. Yeah, 60s maybe, early 70s, 60s. And the concept was the magnets attract nurses and hold them like a magnet. Very little turnover, very high standard of professional recognition, etc. And New Jersey has the greatest number of magnets in the country. And northern New Jersey has the greatest number of magnets. And the magnet status says that we want you, magnet, to have 85% bachelor's prepared nurses. So, associate degrees are not being hired. Nurses that are working there are not being fired. There's an exemption for people who are there. But it's very hard to get a job if you don't have a bachelor's degree, and maybe if you don't have one, but you're enrolled in a program and they can see you're making progress, they may hire you, but it's very hard. So the educational standard is changing despite the law and everything else. And this is happening everywhere in the United States, but more swiftly here again in New Jersey, all right? And the third criteria is autonomy, and that's where we have trouble. Autonomy means you're in charge of your own services. It means that the profession is responsible to monitor its own members and discipline its own members. Now, we've come a long way, but still, many nurses who work in organizations like hospitals, nursing homes, home care, are told frequently to institute certain treatment, nursing treatment for their patients. They might not think it's the best to do, but they do it. You're given a license when you're finished with this program, and when you sit for a state board, you're given a license. And that license says, it figuratively says, your first responsibility is your patient, not your employer. So you want to be a good employee, but you're going to have to constantly wrestle with the issue. What is my role as employee, and what is my role as credentialed professional? And am I doing things which I do not think are best for the patient because my boss tells me? I'll give you an example. No one is in the hospital for very long today. I think you know that. And you're probably gathering, I think that is good. A hospital is a place to get very complex care. Once you're over that stage, get home. Even if your neighbor has to bring you in soup. You know, it's cleaner, there are less mistakes, no one cares like he who cares. And if you don't care about yourself, I don't care about you. So you're going to be very careful what medication you take. You're going to be very careful about getting out of bed to go to the bathroom, that you're steady. You're going to sit on the side of the bed for a few minutes. Not in the hospital. Not that they don't care about you. They care about you. But you're going to see everybody's running around crazy, so I'm going to get up and go to the bathroom myself. You're going to fall on the floor. You're going to break a hip. And I could go on and on. These are not fairy tales. You're best off at home. All right. hospitals want people to go home quick. So let's say the physician in charge of your patient, and still in most hospitals, advanced practice nurses do not have admitting privileges. So the doctor says, I want Mrs. Jones to go home tomorrow morning. You're fine to go home, aren't you, Mrs. Jones? I can see it. And she shakes her head. She's 90 years old. Yeah, she shakes her head. You speak to the doctor right at the bedside. Did you know Mrs. Jones lives alone? That she lives in a single family house and most of her friends have died. I think we could make some contacts through social service, see if there are any church contacts, etc., that could look out for her, but it's going to take more than a day or two. No, I want her out of here tomorrow. She's stable. I'm sorry, I cannot support that. What do you mean support that? You do what I say. No. You go over the head of that physician to your supervisor. You document it in the chart. As soon as you document, you've scared the living daylights out of these people because the chart goes to court. When she breaks her hip, when they're suing, you get the idea. So there will be times you have to speak out on behalf of your patients because your license says that. Your license demands that. Now, let me tell you that bosses do not like people like this, in case you didn't know it. Hospitals want passive people. Any boss wants a passive employee until the smart ones get to know that you're bringing insights they don't have. All right? But most of them, if you're making trouble, want to clear the deck, want to get rid of you. And I know of many nurses who have been asked to leave, not fired because that makes the issue bubble up, but have been asked to leave, have been encouraged, have been given shifts to work which are deplorable on the hope that you'll get fed up and you will leave. But there is a distinction in your license between being a good employee, you come in on time, you occasionally, if they're stuck, will work an extra shift. You're very concerned with the quality of care. Those things all aid the boss and label you as a good employee. Making waves on behalf of the patient doesn't, but it's your responsibility. Yeah.
I have a question. Like example, if the person is like discharged from the hospital and the lady is 90 years old and she's required like the visiting nurses.
Yeah.
Should the nurse be responsible to make all of those arrangements? Who's fully responsible and fully see the needs? The nurse or the provider?
All right.
Or
Every hospital that I know of, and there can be some that are exceptions, but most of them where I practice are in northern New Jersey. Not one of them is absent the talent to do this. It's done usually through social service. Years ago, it was done by nursing itself. But today, nursing is so busy, it's done. So, all right, Mrs. Smith, let's make her 70. 90 is, but there are 90-year-olds around. Mrs. Smith is discharged, and she's steady on her feet. She's cautious about her care. She's a candidate for discharge. But you really are not sure whether she's mastered the education about diabetes, and she's a new diabetic. Also, you think it would be good to have someone regular to look in, and her family has moved to California. That's what you find today. There are no more extended families here. So we have to create them. So the nurse might talk to social service. The nurse knows the most about Mrs. Smith. She knows she's very active in her parish because the Eucharistic minister comes to give communion. And he stays and talks to her, seems to know her. She has a friend that comes regularly who's in her 60s and works. So and she's around a lot except for her job. You give all of this information to social service, and the two of you together plan quickly to establish what networks you can. Social service will arrange for the home health visits. Now, if it's a very debilitated patient, you may need a home health aide for a certain number of hours a day. If it's just checking up and health teaching, you may need a higher level person, but you may need them a few days right away to educate about diabetes and about the diet, etc. If you didn't do it in the hospital, and the nurse will have to speak to the home health agency to tell them exactly what you have taught so that they can pick up the end of that. Also, social service would know whether you can be reimbursed for this or whether this is out of pocket, and whether there is any money from any special programs to pay for it. Also, in this country, it's required that you be given a choice between home care agencies. We recoil at the idea of biasing the consumer, although common sense, and the nurse would usually sometimes social service, but I think it's a nursing responsibility or shared responsibility. If you've been in St. Barnabas for a week or even 5 days or 4 days and been diagnosed there and been educated by the nurses there, etc., I would think that a much more comprehensive picture of you could be given by the staff at St. Barnabas to St. Barnabas Home Care. They operate their own home care. But it's not allowed under Medicare anyway. You have to give the patient an option of 2 or 3 different home cares. When I tell them about that, I always say, "What do you think?" And the person will say, "I've never heard of any of them." And say, "You're in St. Barnabas Hospital, and one of them is St. Barnabas." Admittedly, I'm biasing, but I have no stock in any of them. One is probably a profit maker, and some of your profit makers are wonderful. But it just stands to reason that home care with an office in the same building and the same nurses, sometimes exactly the same nurses, servicing both aspects, could give you a more comprehensive care. That's how it's handled. I believe, and I'm almost positive, home care services and social services are mandatory for a hospital to be approved by the state. They have to have them. Some have better ones than others. For instance, Valley in Ridgewood, I just heard last week, has 10 social workers. There's a lot of work to be done, and they don't want nurses having to do it personally. Nurses are doing other things, so they have 10 social service workers. I know of another hospital closer to here has 1. Come on, what can you do with 1 person? All right, other questions on this? So that's autonomy. Do you have the right to speak out Do you have, as a professional area, the right to discipline those losers among your ranks? Now, the Nursing Practice Act in every state that I know of, but in New Jersey definitely, and remember I told you health, education, and welfare are states' rights. All right. In the Nursing Practice Act here in New Jersey, it says that if you're working next to someone and you have suspicions about their ability, be it that they're not prepared satisfactorily or that you think they may be taking drugs, and you will learn the hallmarks, if you don't know them already, of being able to suspect. I know if someone's on drugs a mile away. You can tell. The speech, the look, you can tell. Well, if you are working next to someone and you see some of these cues, you're under responsibility to report them to the Board of Nursing. Now, you may go a step in between. You may go to your immediate supervisor, if she's a nurse, and explain the situation and say, we are under responsibility to report this person. Shall I do it, or are you going to do it? And I'm serious. The person will get help if the person isn't violating in some way. Now, you have to be careful what you report. Substance abuse is a given. You have to report that. How's it handled in New Jersey? If a person is caught taking or diverting drugs, diverting means you sign out drugs and you give half a dose to the patient, half a dose to me. Sounds horrible to you, I know, but it happens. Or you have a person who's on oxycodone, although that's been withdrawn now, but is on oxy, and you have, most hospitals have devices called a Pixus, P-I-X-U-S. It's a machine that dispenses the drugs, and you can't get in without your code number, which is given to you personally, so they know exactly who took the drugs. And you sign that you gave it to the patient, but the patient is still complaining of pain, and on the next shift calls the nurse on the next shift and says, I have horrible pain. And the nurse says to the patient, and all this discussion is legal, oh, you have an order for a painkiller, use lay language, if you are troubled by the pain. Let me go see if you've had it recently. The nurse goes out, and the patient had it an hour before her shift changed, and she just came on, or he just came on. There's something weird there. So you go in, and you ask the patient, and it's signed for, and it's charted. Didn't you have a pill about an hour ago? Nope. You have to report that. That's diverting drugs, all right? And then the stupid people just take it out of the Pixis and put it in their pocket and don't chart it anywhere. But diversion of drugs is something that has to be reported. If it's proved that the nurse did divert drugs, what happens to them? In this state, they're sent to RAMP, R-A-M-P. It's a rehabilitation program for nurses with substance abuse or mental health problems. In other states that do not have some method of discipline like this, their license is taken away. But we believe in this state that we want to care for our brothers and sisters. So the license may be suspended but they keep it. And nothing appears on their license. In other states, you go into the internet and you go, let's say, Alabama, and you want to check if a certain person has a license in Alabama, their name will come up with a big red star alongside it. You know, there's something. You click and it says substance abuse. In this state, it stays very confidential. Again, value New Jersey. And we've been doing this for some time here. Yeah.
Will others, like employers, know about that? Like if they kind of try to find a job afterwards?
Okay, very good question. What will happen to this person if they try to find a job? If they go into the RAMP program, they have to comply with whatever the caseworker, the case manager, tells them. So the case manager may say, surrender your license temporarily. A lot of people do this. A person who retires, the 90-year-old lady, she's a nurse. She may surrender her license. It means you have it, and you could activate it, but for now, you can't use it. If it hasn't been proven you really did these things, but it's suspicious, the case manager may ask you to leave your job and may work with the boss to have you let go without charges, which means you can apply for unemployment. The RAMP people and the participants in RAMP know every angle. They try to preserve the integrity of the nurse, although their chief concern are the people of New Jersey. You don't want a substance abuser taking care of you in St. Michael's when you go into trauma with your leg hanging off. So you usually are separated from your license in some way. You have to go through a course of treatment that used to, before RAMP, be 5 years. Since RAMP, it's individually determined, and some people only have to go through a course of rehabilitation for a year. Some people for 90 days, if we really can't prove they're abusing substances, but we know there's something there suspicious. All right, what is the course of rehabilitation? It's daily urines. You call in to a hotline every day that you're in the program to see if your number comes up. If your number comes up, you have to go to a testing center, and it's subcontracted. It can be Affinity or it can be LabCorp. You go to one of the testing sites, and you have to give urine visibly observed by everyone and somebody. You can't go in the bathroom alone. Woman would have a woman, a man, but you have to give a urine specimen within the view of someone, and it's tested for drugs. In some people who there's strong suspicion that they're taking drugs, but in some way it clears their system before the testing. They will take a hair sample. A hair sample can show substance abuse 5-10 weeks after you've used it. Okay, a hair sample. And you should be called for a urine sample 3 times in a month. That's the usual. The other days you call in, you put in your number, and they say, have a good day, and you're gone. You go to work or do whatever you. If your license hasn't been pulled, you go to work or you go back to bed. All right? The other thing is you must participate in 12-step meetings. And those will be of your choice. But be it AA, be it Al-Anon, there's an expectation that you go and you secure a sponsor. Then, in addition, you must once a week attend a meeting of RAMP. RAMP has meetings in every section of this state that are nurse facilitated, and there are only nurses there, and they're all nurses who are a part of RAMP. What do they talk about? They talk about their problems. They lie about their problems because you have to lie for a while until you come to grips with what's going on. And it's an hour-and-a-half meeting. Some choose to go close to home, just like AA. Some people choose to go in their own backyard. Others will travel an hour to go to a meeting that is distance for fear of meeting someone close to home that knows them. It's up to them. All right, totally up to them. So that's RAMP. And through this whole process, there is a case manager that you have that knows you, that keeps in touch with the group facilitator in the peer group meetings, that is on your case constantly. All right? And that if you send an email, if things are going okay, won't answer you. And the people in the program get very mad. I send them emails, they never respond. But you remember, they have 900 people they're managing. All right? You're not the only one. And besides, you're a threat to the public. You're lucky you're here. You have to keep in your head that the people at RAMP, you can feel very sorry for them, but they are a threat to the public. And we're monitoring them because the profession says they're trouble. Okay, any other questions about RAMP? That's RAMP, so we will not cover it later in the course. That is RAMP. And that's an example of the profession monitoring its own. We don't ask a boss to do it, although frequently the boss is the one who reports the person. All right? But the profession manages them and disciplines them. All right, so that's the three-legged stool. And the autonomy is the weakest leg because most nurses in the workplace will do what the boss suggests and there's nothing wrong with suggesting. Bosses usually came from the ranks and they know patient care. But it's not that they shouldn't be demanding you do something. They should be consulting with you. And most good bosses do consult with you. All right. The other thing in your reading about the profession, we talked about the minimum database for nursing. And there are 3 tables in your chapter: nursing diagnosis, and NIC and NUC, nursing intervention classification, and nursing outcomes classification. NANDA, which is the Nursing Association, the Nursing Diagnosis Association, has identified a range of conditions that nurses treat on their own, like if you have poor preventive health practices, if you have stressful relationships with your family, or if you're in jeopardy of stressful relationships with your family, if you don't know how to handle your own anxiety. These are all, and I think the one in your book is anxiety. There are ways to handle that, and you're taught them here in school while you're here. And the outcomes would be that you're much more in control of your life. Your anxiety is lower. You're functioning much more productively. Those are the outcomes. Make sure you look at those examples in your book. Indeed, a whole nursing curriculum could be derived from Nanda, Nick, and Knock. And Nanda, Nick, and Knock, I just love the way that melodiously falls off your lips, you know. Nanda's the diagnosis, Nick, intervention, is the interventions, and Knock is the outcome. They were developed at the University of Iowa, and the Center for Perfection of these tools, and they're constantly researching, is still at the University of Iowa. Another example of public-private sector partnership in this country. Now, how is that public? Is it public? It's public because in the National Institute of Health and all the other governmental databases, these terms are used. Nanda, Nick, and Knock. Not only the name of the classification, but the items under these classifications are used to classify things. And if you go into the National Library of Medicine and you're doing work on anxiety, and you put in the nursing diagnosis for anxiety, it will bring up all of the things that have been written lately on anxiety. All right? So they're recognized by the federal government. They were developed by private sector, and they're still being worked on daily at the University of Iowa in its center, which is heavily government funded. Government gives the money to private sector to do the work for government. This is a uniquely American model. Remember, we talked earlier about the fact that if you're accredited by the Joint Commission, that's the accreditation of hospitals, you can receive Medicare reimbursement. If an older person chooses to go to a hospital that's approved by the state, because you can't stay open if you're not approved by the state, but it's not accredited by the Joint Commission, they theoretically have to pay the hospital and get their money back from the government. Government will not pay directly a non-accredited hospital. Accreditation means quality. Right? So Nanda, Nick, and Knock are very important. Another thing that's very important to have a sense of, not to be an expert in at this area, but to have a sense of, is nursing theorists. There are three types of nursing theories: philosophical, grand theories, and mid-range theories. It says so in your book. It says so on the slides. You don't have to remember much. There are three types of nursing theories, or theories to guide practice. And there's a chart in your book, and if you look, the major nursing theorists are there, and I don't expect you to be an expert on them. These will be talked about extensively through your program of study here. Does Rutgers propose one theory is better than others? No. It's all your personality, what you like. Some places, there are some schools of nursing that teach primarily to one theory. Seton Hall University teaches to a theory called self-care. And the creator of that theory, the person who did the most work on it, is Dorothea Orem. She's in your list. Self-care. And it's a very simple theory until you dig into it. Self-care says that a person, you and me, are responsible for our own healthcare practices and to look out for the self-care of others who may be dependent on us. If you have a child, You're not only responsible for yourself, you're responsible for your child. If you have someone with developmental delays, you're responsible for that person as well as you. If you have a 100-year-old mother that does not have the ability to do for themselves, physically or mentally, you're responsible for that person too. And Orem specifies for what? She has a list of universal health care needs. And then she has a list of situations in illness that you might become involved with. Why would it help to use a theorist? Because it helps you in your assessment. You can quickly remember the major pieces that you've been directed to by studying this theorist. Rutgers' approach to theory is that we are eclectic. Eclectic means you blend a lot of different theories. And in the leadership course, I think it's in that one, in the last course when you're a senior, you'll go into depth on nursing theories, and you'll actually have to design care according to the theorist of your choice. And it may be that when you go out and practice, you're still eclectic. Now, do I use a theorist and I practice? When I went through nursing school, nobody taught theorists. Theorists are something that has become very prominent in the late 70s, early 80s, and carried on to this day. There wasn't theorists. There was not when I was in school. But as I became schooled, educated in the theorist, I realized I had been using one. I had been using self-care because I believe people should take care of themselves. Then if we're going to take care of them, why are we educating them? We're educating them to do for themselves. So that's my philosophy. It may not be yours. William Patterson, out in Passaic County, you're all familiar with William Patterson University out there? They're built on adaptation theory, which is a theory developed by Callista Roy of Boston College. She's still there. I think Orem's dead. Most of them are dead. Callista Roy is very much with us. She's a Catholic nun. And her theory is very unique. And every theory, and in your list of books to go to for enrichment, there are a few books that talk about many theories. It's fascinating. She believes that every person has a sort of an invisible line around them. And the line has breaks in it. It's like a dotted line around you. And if a threat to you breaks through that line, you need nursing care. Like you're a diabetic and you don't know how to take care of yourself. It broke through. And the nurse has to educate you so that you push diabetes outside that line again. And it's something outside of your persona. A brilliant woman. And reading about what she means by her theory enriches you. Any questions about? And William Patterson, yes?
That's the adaptation.
Adaptation. Callista Roy. William Patterson, I don't know how they do it. I've never gone to a class up there. But all of the clinical education uses Callista Roy. NYU in New York, Martha Rogers, the theory of unitary man, and that's a mind blower. Now, NYU has a very small undergraduate program for the BSA, and it has a very large master's program and doctoral program. And at one time, every doctoral candidate that came out of NYU did a project based on the unitary science of man. And the developer of that was a lady called Martha Rogers. And it's a very complex theory based mostly in physics and the natural sciences. And she did a lot of her research here at New Jersey Institute for Technology. And I went with her. I knew her. She used to come over here. She developed the therapy of therapeutic touch. Therapeutic touch is a nursing therapy that is based on the theory that we all have energy in our body, but when you're sick, it's maldistributed. And her disciples, and she's dead, but a lot of her disciples are doing therapeutic touch. We have a doctoral student right now here that's studying therapeutic touch for her dissertation. And Martha Rogers used to come over to NJIT. There was a scientist at NJIT that did a lot of work with Kirlian photography. Now, what is Kirlian? It's a methodology that was developed in Russia years ago, and he taught here. And I think it's pretty commonly known now, where they take pictures of you with certain types of cameras, and your aura shows around your body. Your power sources will show around your body. And where there's a break in the aura, that means there's something wrong. And that's how she developed her therapeutic touch. Fascinating. But it has a lot of practical things in it, too. She felt that people are in constant exchange with the environment. You see, this fits right in with the Kirlian. She felt that as you are getting closer to death, you should disengage from the environment. All right, some of the doctoral studies that were done under her, since she is dead and left, there's less influence at NYU from her theory. Like there was a study done at NYU on how patients responded to color in intensive care. And I'm not qualified to tell you about the sample and about everything in the study, but it was the first attempt to dress people out of white, doctors and nurses, into colored scrubs. They wore scrubs before, they were all white. And they found that where the staff wore colored scrubs, they were more compliant in their care and they recovered quicker. Now, the recovery may be going to a step-down unit a day sooner, but that means a lot economically, all right? The same type of color focus was tried in pediatrics to see if kids were more comfortable and less anxious when they had people who were dressed in pinks and yellows versus the harsh colors. You know, the harsh scrub green, and some hospitals have navy blue, and there was a notable, but not highly significant, but a notable improvement in kids' attitude and their comfort while they were in the hospital. And every kid can't have a parent there, all right? Another study she did, or her disciples did, these were all doctoral dissertations, and you probably could go into university microfilms. Every dissertation that's ever been done is stored in university microfilms at the University of Michigan. Again, public and private coming together, all right? But another study was based somewhat on circadian rhythms. You know what a circadian rhythm is? Circadian rhythm says that every one of us has a time of the day when we perform better and a time of the day we perform lousy. All right? And her student matched up the downtime for the patient with the uptime for the surgeon. And they had much better results post-operatively. Like, you find out, and there are tools to find this out, what is the downtime for you? What is the time that you're your least productive, put it that way. I'm least productive this time. I'm up at night till 2 in the morning. I go like fire at night. If I'm writing something, if I'm thinking, I don't mean that you're getting poor product at 10 o'clock, but I would rather sleep till noon and work till 3 o'clock, all right? And I know that. So if I have a piece of very intense thinking to do, I'll do it at night. And everybody in the house is sleeping. Occasionally, when I had kids home, I'd have someone come down, Mom, are you still up? And I'd say cheerfully, yes, I am, go to bed. And but that's my uptime. My downtime's in the morning. The doctoral student profiled each case and got the cooperation of the doctors. Well, of course, they wanted to operate in their uptime. That's the time they felt most with it. And the patients, they had to accept. And put them together, and they had much better post-operative results. No problems with breathing. Anesthesiologists found they could give less gas. This is critical in anesthesia. The less gas or less anesthesia, whatever kind, is given to you, the better you will recover. Because you're coming out of the anesthesia by the time you're leaving the operating room, and you can be urged to breathe immediately, and versus someone that takes a lot of gas or a lot of medication, is deep under, and you have to wait hours for them to recover. So this was another one of her studies she worked with doctoral students to do. So a lot of genius that, and I have had students in here who have chosen to investigate another theory. And they weren't looking, because there aren't many debates against theories. There's more or less acceptance in nursing that you use the theory that fits you, all right? But what they would do is tell us about the theory, then in a second part of the paper, apply it to a case, and you find many case applications in those books I have listed. Most of those authors talk about the theory, then apply it to a case, and then a concluding statement about your observations. It's an excellent thing to do. All right, so there are the philosophical theories, the grand theories, and the mid-range. Philosophical theories are ones that don't tell you enough to operate on, but we'll let it ring. That don't give you enough to operate on, but shape your thinking. Mid-range theories are ones that give you direction to weave your care around, but they're so broad they could be applicable to any patient. Martha Rogers was also responsible heavily for rooming in obstetrics, all right? And for socializing the baby into the rhythm of the parent that they were going to meet when they went home. So that at NYU Medical, if you have a baby and you're going to stay your one night there, and you work nights, and you want the baby to feed more lustily and to be awake more during the day, you will start that process in your room, leaving all the lights on all night, if that's when you're home. Well, anyway, you get the idea. So it has practical application. And mid-range theories are ones that are specific to a certain population or a certain area of practice. The one you should know is Peplau's theory. Hildegard Peplau was here at Rutgers for many years. She came from Teachers College, Columbia to Rutgers and set up the first master's program in clinical care in the nation, in the world, really. And she has what is called an interpersonal theory of nursing. And I hope they're teaching it here in undergraduate when you get to it. It's a very specific way of dealing with patients. And it's heavily based on some of the very famous psychologists and psychiatrists that went before her, but it's nursing. So interpersonal. And there are many others in your book. For instance, Joyce Travelby, and she was a disciple of Peplau's. And when you see in the book that this one was heavily influenced by another theorist, usually means that they studied under them, they went to school in a place where they taught. Travelby is a very unique theory. She believes that, she's dead, but she believed that illness is a learning experience, and the nurse learns with the patient. So pain is part of your learning. Cancer is part of your learning. Learn all there is about it, learn to deal with it. And there are many others in there, and you can, if you're interested, I would, all right, the philosophical theories, two main ones, Nightingale and Henderson. Henderson is frequently called the American Nightingale. She came from TC, from Teachers College, Columbia. Again, everyone came from TC. And she served most of her professional life at Yale. And she was the person who said nurses exist to do for people what they would do for themselves if they had the resources, the education, the emotional climate, etc. Very pragmatic. And she was a genius too, but she was probably the earliest contemporary theorist. And Nightingale's theory weighs heavily on the environment, and you can see it if you read some of the books, like Notes on Nursing. There's a little bitty book, but it was written by her, contains her philosophy. The first thing she did when she went to the Crimea, and we're going to study Nightingale in a few weeks, but when she went to help the British were fighting in the Crimea, which is near Russia. And 96% of all the Brit soldiers who were admitted to the hospital died. 96%. You were going to the hospital, you knew what was next. And she couldn't accept that. So she got over there with her bunch of nurses through devious means. We'll talk about that later. But when she got there, the first thing she did was to clean the environment. She had them scrubbing. And she had all of the wounded soldiers brought out into the air for as long as daylight continued. They all got baths. She had the nurses boiling the sheets outside in cauldrons like witches to get rid of the bacteria. She fed them. She invited, at that time, families went with the soldiers to war. She invited all of their female partners in and put them to work cooking so that there'd be some decent. Her emphasis was the environment, and it worked. Within something like a month, only about 6% of the people were dying. And that's what made her famous. But she's an environmentalist. And it's a philosophy. In her mind, the doctor was the boss. And she says this in her writing. Nurses are not the boss. So we don't like her for that, but she did a lot of other good things. So to look through those theorists, one last comment. The major concepts in every theory, and the ones that will tell them apart if you study them very intricately, are man, health, society, and nursing. Those four constructs. And a construct is something you can't see or touch or feel, the ideas. Man, health, society, and nursing. Each one of them, see each of them a little bit different. Man, aurum, take care of yourself and those who are dependent on you. Universal health care needs. Health. Health is what you see it to be. Not what I say, but what you see it to be and what allows you to move on in life. Man, used generically, to her, are you and your support systems. So nursing is what nursing does, and she has a very specific prescription for that, which builds heavily on Henderson. In aurum, you do for a patient that which he cannot do but what he would do for him. It's almost aurum. And she builds her thinking heavily. She's aurum. She builds her thinking heavily on Henderson, Virginia Henderson. Okay? One other thing that you have to understand is that nursing is a science. And as a science is a group of constructs or concepts. And for nursing, there are those big four, man, health, society, and nursing. And there are relationships between those concepts, and that's what gives you a theory. So if you, I think it would be very worth your while, if you're looking for a title, to look over those theorists, seize one that particularly gets you, makes sense to you. Go read a little bit more about them. Go to Google. I'm a fan of Google. But Callista Roy's work is up on Boston College's website. She made that happen, and she's a very nice, low-key nun. But she is forceful intellectually, and you will find enough on that website to understand. All right? And try it with the others. If not, go to those books that I've suggested. Apply it to clinical as much as you can, not having had clinical, and then draw some conclusions. Is it something you would be comfortable with? And you surely, it is an opinion, you surely will have some opinions. It has been said that aurum is not appropriate for other than the U.S. That I've heard her speak. She died lately, but I've heard her speak. And she admits that. Why? Because in all cultures, you're not responsible for yourself. In some cultures, the family is responsible for you. Any of you come from that culture? Well, not here. Here, you're responsible for yourself. But a lot of what aurum talks about would be inappropriate in some of those cultures where you're not responsible for yourself. Even if you're an adult, the big decisions, and by big decisions, I mean sexual identity, abortion, those decisions are made by someone else, the leader of the family, on your behalf. So, Orem self-care would not be appropriate, but it would make a very interesting think piece for your paper.
How do you spell Orem?
O-R-E-M. And you'll see her in the list in your book. Orem, Dorothea Orem. All right, where did she come from? Where was her work taught? Taught very widely, but it was taught specifically in Georgetown University, and she was on Georgetown and Catholic Hughes faculty for many years. All right, why don't you take a break? And I'll work on this again. But no, it's very important at the start. And then this is a personal responsibility. And it comes back to one. And you don't know. When you put it in the second and that would be circle around. I didn't look, but the people here in the office said it's all right.
You don't want to be here. Also, you think
I'm just saying.
Last week.
No, I agree with you.
And it's like so.
I would take you like this. No, I mean everybody.
Yeah, they should be.
How long ago did you see it?
I just told you that.
And what did he say? I would give it a chance, but if after 2 weeks, then you have to. No, you didn't. Oh, for autism. I thought I had an opinion, but after doing research, like our research, I would question, I think, well, I personally think that many and that is very diet, stimuli, first, okay? All right.
you get a tour? No? Just imagine.
Sorry. It's not working. Thank you. Good though. Okay. We're going to go on and talk about nursing education. Those are the next things we're going to talk about: nursing education and issues in nursing education. You all know, I suppose, that there are two principal ways to become an RN, right? You are in or aspiring to be in a baccalaureate program, then there's an associate degree program. Until very lately, there were more associate degree graduates than any other types of graduates. When did the associate degree program come on the scene? Associate degree nursing is relatively recent. The traditional program for education of the professional nurse is the diploma school program, which was largely practice and much less theory. But as healthcare became more complex and as patients became sicker, it was noteworthy that a different type of education was required. Now, the beginning of the AD program takes us back to World War II. In World War II, there was never a draft for nurses, never. It did come before the Congress several times, but it never came up for a vote because the nursing community produced the information that we had enough nurses and that nurses were quick to enlist in the armed services during the war, and they were. I hardly know a single nurse who during World War II was not in the military. As soon as there's a war, nurses come forward by the millions to enlist. Now, why do I say a single? Because now I always push the military as a career for anyone because I have an awful lot of friends and in the military, and I've done work for the military. All of the friends I have that are in the military, and they're pretty high status in the military, had children and have children. You don't have to, as a woman's profession, you don't have to avoid the military because of children. In the olden days, you did. You were discharged. No more. There is a great deal of desire to keep families intact so that you are stationed where your partner is, the two of you, man or woman, they attempt to station you close. There's child care. There are all sorts of benefits of them. I don't want to be here giving you a sell job for the military, but were I of younger years starting off in the profession, there's no doubt I'd go the military route. It is a community of its own, man or woman, and there are more men in the military than women, and there's a very high percentage of male nurse anesthetists in the military, very high. And now advanced practice nurses. And if you decide to go the military route while you're in school, you're given a commissioned officer status immediately, and you're paid while you're in the military. I mean, who could say no to that? But I just want to tell you, it is a wonderful option. And you're probably thinking, but I have to give back years. Well, you're in nursing for life, I hope. I started working when I was 12 years old. It sounds like my parents violated the child labor laws, but I was 12 years old, and I've never had a day off since, even when I had children. I was off a week and came back and brought them in a carry-all and put them in front of the class. So you're in this work for life. And since you're in for life, and the people who progress up the scale the quickest are ones who are willing to move. In the VA, the VA is a wonderful career, but you have to be willing to move. And I know many VA families, they base a lot of their policies on the military. They attempt to keep families together. They do keep families together, and they help wives get jobs where husbands have been transferred to be with the VA. Tremendous. The chief here at the VA in Orange is from Florida originally. He's just fantastic. He's a career VA person, and that's how you have to envision your life if you're going into one of these services. But, all right, back to the associate degree. There was an observation. I wasn't around to make it at the time, but the literature tells us. There was an observation during World War II. They put out a call for nurses to enlist. They got plenty of enlistments, but coming near to the end of the war, they were starting to need more nurses. And they had exhausted the civilian ranks. So what they did, they designed a new program called the Nurse Cadet Corps. And the Nurse Cadet Corps allowed you to go into a school of nursing, and they were all diploma schools at the time, but you went into a school of nursing and you completed your studies in nursing in less than 2 years. You went, I had cousins who were in it. It was a horrendous program, supposedly. You went to school 12 hours a day and no bitching about it. You signed up. You were given a stipend. I don't think it was a commissioned officer, but it was a stipend. They paid for all your education. And in a less than 2 years, you were out. There was almost no clinical experience given. This is important to hear. Almost no, all theory, science, 12 hours a day study. And when you came out, it was assumed you would be linked with a registered, or everyone who came out went in the service, unless you were pregnant, because they still didn't take pregnant people. But everyone was required to go in the service, and you were linked up with a seasoned nurse in the service. And that seasoned nurse made sure you got the experience you needed. So, after the war, a woman at where? Teachers College, Columbia, TC as it's called, named Mildred Montag, wonderful woman, got this brilliant idea. If we could do it during war, why can't we do it at peace? Because after the war, there were a lot of deficiencies among the nursing ranks. They needed nurses after World War II. So she came up with this plan. It was funded by the Kellogg Foundation. Kellogg has always been very generous to nursing. And it happened in where? New Jersey. It was initiated in Fairleigh Dickinson and Rutgers. And they were the first associate degree programs. The problem is that, and Mildred Montag designed the curriculum to be 2 years in length. The associate degree, the community college movement, before World War II, the community college movement was very weak. It was mostly for people who came from means and had to be finished off. It gave you a certain amount of literature and mathematics, enough to be beyond the high school, but not a tremendously educated person. Montag saw that this was particularly an interesting place to educate nurses because GIs got out of the service with educational benefits for institutions of higher education and community colleges qualified. So she designed her program to be 2 years, which was the community college, was a 2-year program for many people pre-baccalaureate. But after World War II, they advertised the community college as a way for people to get a job in life. All right? It became very oriented towards jobs and very oriented towards vets. Nursing was one program, and it was still chiefly female, but there were many other computers had just started to show their head above the water. So computer programs. Even in some community colleges, the trades, plumbing and carpentry. And they still give those things in some community colleges in this state. But she designed a 2-year program for people who wanted to be nurses, to be given in community colleges. And her vision was that there would be almost no clinical work. You would graduate and you would go to work in an institution which would give you a quote, she called it, a residency. And during this residency, she didn't talk about what you should be paid. Those are the labor issues. But she thought you should then go into the workplace where you would not have full scope of practice responsibility. You would not be expected to do everything a nurse does, but you would work under the direction of the institution and of seasoned nurses who were there. Now, the hospitals, of course, contorted the whole idea. And with time, clinical practice was put in the course of studies, like you have now. And the state board started to license these people when they finished the course of studies. So you got people who were not really adequately prepared for the full scope of what nurses do, being put in positions that were way beyond them. And that's the nursing community's criticism of associate degree programs. Now, even today, associate degree programs in many places, less so than years ago, but still, the students in associate degree programs are older than the average high school graduate. I was up at Bergen Community this week earlier, and they said their average age is late 30s. And a lot of their students are what they call displaced homemakers. I hate that term, but it is a term that's legally used in unemployment. If you're a displaced homemaker, man or woman, doesn't matter, unemployment has money to train you for work. And a lot of these people are sent to associate degree colleges. It's cheaper than sending you to a 4-year baccalaureate. Although I'll tell you, if I had some years in education and I was unemployed, if I was deserted by my wife or my husband, I'd go to unemployment and make a case that 2 years at Rutgers to finish what I have isn't going to be any more than 2 years at a community college. Community colleges are cheaper, I know that. But I try to hold out for a senior college. Anyway, associate degree graduates are older, and many of them are people who go back to start a second career. And that's why I think they could get along on the education that's offered right now. Because when you meet with them, I don't know if you have friends in associate degree programs, but they're a very bright group. They bring a lot of life experience to the program. But they've been misadvised. Because you could come here, and if you, many of these people have bachelor's degrees in other areas, you don't go to a community college. You can finish an accelerated program here in 18 months. So to go to a community college is tantamount to disaster today. You just don't go. But Mildred Montag thought up the idea. Her book, Technical Education for Nursing, that's the name of the book. I think if you went on the Rutgers Library, etc., you could get a copy. Fascinating to read. She never envisioned it like it turned out to be. But it was distorted because all of a sudden the hospitals and other places that nurses work could get a lot of nurses quick and cheap. So it was distorted, but it was not her idea. And she was a grand lady. I had the privilege of studying under her, a very visionary woman, and she started all this mess we're in now. Not due to her ideas, but she started it. All right, so we have associate degree programs. We have baccalaureate programs. The baccalaureate is the preferential program. Clearly, you're in the right place. And we have a lot of other programs which are hybrids, are deviations from the common ones. One of these is the entry-level master's program. If someone were to come to me that has a bachelor's degree anyway, I would counsel them in there are entry-level baccalaureate master's programs. You go in and you take your licensing exam after you complete the nursing studies, but when you get out of the program, you get a master's degree. And a master's degree is a lot more potent when you go to work for it than even a bachelor's degree. Of course, you have even entry-level doctors of nursing practice. We'll talk about them in a minute. That's a new degree. And you have some diploma programs hanging on. I was at Atlantic City yesterday. I didn't put one dime in a slot machine, sorry. I always have this dream, because it happened to me once. I only got $5, but I put a quarter in a slot machine. It was out in Las Vegas. I was at a meeting. All of a sudden the bell rang and all this money came out, and it was about $5. I thought it was like $100. And I have this vision, but it never happened again. The New Jersey nursing students had their convention in Atlantic City. Were any of you there? I don't think you're that deep into nursing yet. Please join. It's Rutgers nursing students. They have their own chapter here. It was a day and a half of wonderful programming, the keynote speaker was Irene Zungalo. She just retired as the dean at Duquesne University. She was really wonderful. And I only went for the day, but the day went from 9 o'clock in the morning till about 6 o'clock at night. And then they had fun things at night. But what got me, they gave out scholarship monies. They always have a lot of money. They get it from drug companies and other places. Wherever you can get it, take it, is my philosophy. And you had to apply for the scholarships. Well, obviously, diploma schools applied for the scholarships because all the scholarships went to Christ Hospital, Mountainside Hackensack. Hackensack Hospital has bought Mountainside. You should know these things, especially for your job market later. Hackensack is the biggest personality hospital, the most credible in this state, Hackensack and Robert Wood Johnson. And Hackensack, just about a year ago, bought Mountainside. And Mountainside had a diploma school. Hackensack closed theirs 20 years ago, but one of the deals, I guess, was that you take our diploma school, and so it's now Hackensack / Mountainside. And the other, no, they were the only two, but all the scholarships went to students of theirs. And even the keynote speaker put a foot in her mouth. She, well, not really. She can say what she wants. You know, you invited her. If I said it, they'd ride me out on a rail. But she noticed this, and she said, if you students have the intelligence, because she asked for the criteria, to successfully achieve these scholarships, what are you doing in that program? Oh, you know, everybody was thinking it, but no one had the nerve to say it. But she's the keynote speaker, and she spoke twice, and everyone thought she was wonderful. I wonder if they remembered her comment. She said, "You've been misadvised. You shouldn't be in there. You should be in a baccalaureate program." So, but the baccalaureate programs were not very visible at the convention. So we still have diploma schools. We're one of the few states that have them. There is none west of the Mississippi. None. Nada. So we have diploma schools, associate degree, baccalaureate, and master's entry into nursing. That's a degree where you take your state boards when you're finished, entry level. Master's programs in nursing are quickly on their decline. Instead, the profession has adopted, and there are 300 Doctor of Nursing practice programs, either in development or established today. Rutgers has one master's program left, and I don't know why they keep it, in nursing. It's called a Master's in Leadership, and it prepares you for middle management positions like head nurse, supervisor, those type of positions. And it's a very good program. But all of the other master's programs last September were admitted their last class. Now they are Doctor of Nursing Practice, DNP programs. And they prepare you for clinical practice in a specialty area. So if you decide to go there, you're going to have to decide what you want to be when you grow up. In other words, what types of patients you want to care for. And we have programs here to prepare a family nurse practitioner, an adult nurse practitioner, pediatric nurse practitioner, geriatric nurse practitioner, psychiatric nurse practitioner, and I think that's it. What does nurse practitioner mean? Nurse practitioners offer primary care services. So if you think back to your definitions 2 weeks ago, remember I said they'd be important. Primary care is care of people to make them healthier, to avoid disease, and to take care of minor illness, and to take care of people with chronic illness who have been stabilized. All right? If they have a serious chronic illness we don't deal with, although some nurses are beginning to. But if you've been stabilized by a physician and are on a regular therapeutic regimen, the primary care nurse can take care of that, can even adjust your treatment plan, can treat all sorts of minor illness, arthritis, unless it gets very complicated, but colds, pneumonias, all of the usual acute illnesses that if they're treated correctly and go away, you're in good health again. And can treat people who want to stay healthier, like children, pediatric nurse practitioner. It's rare that a child would need a pediatrician unless they get into some very serious illnesses. All right? And that is the nearest analogy I can give you. And it's always said, most pediatricians find it very comfortable working with nurse practitioners, pediatric nurse practitioners. All right? So that's the doctor of nursing practice. Now, what things are in the doctor of nursing practice that were not in the master's degree? To complete a doctor of nursing practice, you have to do a major project, which is called a capstone. And if you want to study this for your paper, do so. It's a shame you didn't know a week earlier there was a program here put on by the state nurses for free for students up in Bergen County last night on the doctor of nursing practice. It's new. Where did it first come from? Columbia University. Their dean was one of the promoters and one of the designers of the first DNP program. And it's only operating 3 or 4 years. What are the arguments? Doctors hate it. Why? They say we have no right to be called a doctor of nursing practice. That doesn't upset you? You sit there. All right, that would make a wonderful paper. And there's been so much written about it. They will tolerate doctors of pharmacy and doctors of physiotherapy and even doctors of occupational therapy and respiratory therapy, but a doctor of nursing practice, that is too much. It's too much because there are 3.9 million of us. You realize that. And once we're all called doctor, medical practice has waned seriously. But that is the newest edge on practice. All right, you have to do a capstone project. And the capstone projects are fascinating. When a student finishes their project, they present it here at the school. We have a very big DNP program. And if you want to, I could tell you when there is one. You can go and hear what they're like. All right, one student. And the DNP is all online, too, if you want it. One student established a website in Florida for Latino women. She's up to millions of hits. Where'd she get the money to do it? You have to go out, and you go to someone. I think she used Goya Foods. And it doesn't take a lot of money to establish a website. It's not hundreds of thousands of dollars, but it does take money. The website explains things you should do to stay wealthy, rights that you have, explains the phenomena among women that family comes first before their own health. I don't know if you've noticed this, and it's particularly prominent among Latino women. They work, they take care of the house, and they take care of the family, and a major portion of her website, I know in the beginning, this was last year, focused in on that. Now, I wonder how the Latino community liked that, but she thought it was necessary for women to hear it, for women to realize that they weren't standing alone when they had gripes about the burdens they were carrying. Masterful, and it's still operating. It's a practice project, but not research. The other, it's the terminal degree for practice, DNP, right? The other terminal degree in nursing is the PhD. And that is a degree that prepares you to do research. It's different from the DNP. The only other degree you will see in nursing is the EDD. Very few of them. My degree is an EDD because the school I went to was not allowed to give anything but EDDs. It was a long time ago, and it was TC, Columbia. Anyone with an EDD is a graduate of TC because it's a degree in nursing, but they were not allowed by charter to give anything but the EDD. They're based in an education college. All right. So these are exciting days for nursing, and the DNP is just as difficult as any other doctorate. The core curriculum are things that enhance your practice. That's what the degree is suited for. There's a capstone project, and there's a residency as part of the degree. As part of the degree, you're out there working too, and the working will prepare you to start out in an advanced practice role, APN. And APNs in New Jersey are recognized by the Board of Nursing, and you have to have a national advanced practice certification to qualify. All right? So that is the workplace, the educational marketplace. Yeah.
EDD, is that also considered a terminal degree?
Yeah. An EDD equates with the PhD. Is Teachers College, TC, still giving them? Yes. But I would not encourage anyone to go into the program because the PhD is what is required in most places if they're looking for a research degree. Now, what's the market for employment with a research degree, a terminal degree? The market for employment is the professorial role, teaching in higher education, all right? Or there are more and more positions in health organizations for people with research degrees. For instance, Robert Wood Johnson down in New Brunswick has a PhD nurse that is totally involved applying for monies for research and identifying the research problems that they need work on. Hackensack has a PhD nurse who fulfills the same role. Meridian has one. In fact, I believe Meridian and Hackensack have several PhD nurses. Now, salary is another issue. You're going to make much more in the service sector than going to teach in any school. Some of you may know that, but that's the reality of it today. So you find a lot of PhD nurses, many of our graduates, are employed in hospitals throughout the state. Or I can think of one who graduated last year who's with Merck, working in research. PhD nurses are fully prepared for research. DNPs are not. So if they're employed in research, it's false advertising. They shouldn't be there. All right? Any other questions on the DNP, the PhD? There are still master's programs around. We have one here in leadership. There are still some in the country, but they're quickly converting to DNPs.
So DNP is just basically like the most advanced practice.
It's the terminal degree for practice. Yeah. The PhD is the terminal degree for research, and it's required if you're going to teach in higher education. Now there's one more degree to confuse you a little more. All right. The master's comes after the bachelor's, and the doctorate comes after the master's. And what I'm telling you is, you can go right from your bachelor's. You should work a little to get a sense of what nursing's about. Because working as a student does not really give you a full sense of what nursing's about. But you should go on, if you want your terminal degree in practice, to a DNP. You can do it part-time. You can do some online. But there is a master's station that exists. And some places will give you a master's while you're going for the doctorate. Do you follow me? In other words, you didn't sign up for the master's, but you can opt to take it. And you should, if you can. At Rutgers, I don't believe you can. At TC, you always could. You could take a Master of Education after your bachelor's and then go on for the doctorate. All right? Even though in your head you didn't see it as getting the degree, they awarded it to you. All right. There's one more degree you should know about. The Clinical Nurse Leader, the CNL. Now, the CNL is a master's degree. The name of the role is the Clinical Nurse Leader, CNL. But it's a master's degree. And it's a master's degree in nursing. It prepares you for advanced practice generically. In other words, it's more than you would need to get the RN. Although most of the people in these programs, and there are quite a few in the country, and there's one in New Jersey, and it's at Seton Hall. It's heavily externally funded, and usually it's developed in partnership with healthcare facilities. At Seton Hall, it's a partnership program with Palisade Medical Center in North Bergen. It really, I always think it should be in Edgewater, but it's right on the Hudson. Do you know where it is? Palisade General. The one with the orange spaces in their parking lot. I always have to tell you that. And they have a notice that if there's heavy rains, don't park there because your car will be underwater. And I once saw it coming above my tires and got the car out quick. They're so near the bank of the Hudson. But they have a clinical nurse leader. They provide the clinical experience for the Seton Hall students. And the students are given a heavy dose of management skills. And there's a lot of clinical experience, but you're not a specialist. All right? That's the variable. You're not a specialist. Where in most other master's programs, when we had them, you had to select a clinical specialty area. So most of the people in the clinical nurse leader masters are prepared again for middle management positions, much like the master's degree here at Rutgers in leadership. Their graduates are very impressive. I met a bunch of them. They were down at the student convention last year, and Seton Hall gave a social at night, I think, to front stage them. They're all older. Equal numbers, men and women, in the classes. A lot of vets and corpsmen from the military. They're definitely nurses, but they're prepared to assume a higher role in nursing. And Palisade General, now why? What are they doing? Just providing the patients for them to work on? No. They've restructured half of the hospital to use them as they were prepared. And they put them, graduates who want to come to work there, who went through this program in those roles. In other words, they're used as case managers for patients. They're used as the clinical consultants to staff nurses. And they've done very, very well. They've collected the information to show it's cheaper, hiring them, paying them a little bit more, and putting them in these positions. So that's another role you should know about, clinical nurse leader. I'm surprised it hasn't taken on more. But about the same time as this role, the clinical nurse leader became apparent, the doctor of nursing practice came on the scene, and I think everybody thought they were getting more if they got out with the doctorate, if you follow my thinking. It's a shame, because the clinical nurse leader and the students that are in the program are mostly older students. You talk to them, they really appreciate what they're being prepared for. They are not going to sell themselves cheap. They demand certain salary and certain autonomy. All right, that's what you're getting in this. So that is the other new role in nursing. Now, as far as the issues in nursing, a lot of them, when you read, will be familiar. Distance education is an issue. I cringe when I hear Grand Canyon University. Where the heck? I know it's in Grand Canyon, they say. But their dean lives in Lowell, Massachusetts. You can't fool me. I know her. When I read her name, I thought to myself, what's Marie doing out in the Grand Canyon? A girl from Jersey City out in the Grand Canyon. She wouldn't know the Grand. Well, it's a totally online program. But then I ask myself, how are they guaranteeing competency in the laying on of hands skills? You understand what I mean? How do they guarantee competency? There are ways to do it. And if you want to do a tremendous paper, do one on these new innovative models. In Florida and in the state of Washington, all community colleges, associate degree nursing programs, have been given the right to award bachelor's degrees. State of Washington and Florida. And there is a piece of legislation in committee in Trenton right now to allow our community colleges to give bachelor's degrees. Know that it's a reality. What do you think of that? You could get plenty. There's been plenty written. Read on it. It's an opinion piece, but it would be wonderful if you picked that up. What do you think of these new programs? Go reading, and don't lay pen to paper until you feel you truly understand. If you don't, get in touch with me. We'll meet after class, discuss it, if there are a few of you interested. But there are issues. One is distance education. I think that's becoming less of an issue as students expect it. Students here expect it. It's not prominent in the undergraduate program, very prominent in our masters that we had and in the DNP. Very prominent, distance education. How do you learn? The external degree programs, those are programs that give you credit for taking courses anywhere. It started years ago with the Regents external degree in New York State. Regents is not now called Excelsior College. Go in and look. They give master's and bachelor's degrees without you ever appearing up there. But they test out your practice skills in locations they have around the country. That's another issue, a very debatable issue in nursing, another thing you could read about. All right? For the most part, though, nursing education, no matter where you choose to be educated, has the same big issues. We need clinical sites, which are not so ready to give because most students, you link them to a practicing nurse, it's going to take time away from her work. And employers don't want this anymore. Medical education has always been by apprenticeship. Doctors felt very proud to have a medical student attached to them. Same has not been true about nursing. Of course, we have a lot more to educate. All right? And secondly, due to the fact that we require clinical education and there's a mandatory cap on how many students with a professor, 10 to 1. And the state board defines it in this state. And they are even in some areas frowning on 10 to 1. How could you handle 10 students in a critical care or a step-down unit? You couldn't possibly. It's too many. So we're very expensive. Nursing is a very expensive program. I know you feel you're paying a lot, but it's nothing compared to what it really costs. All right, any questions at all? And there were a few of you that came up and asked about your papers during the break. Next week, be prepared to start off the session talking about your papers. Please get used to asking the questions out loud. All right, thank you very much for your time. We'll have to ask the computer guy to come.
That guys never came. Hello, Ping.